Thank y'all for coming. This is going to be very informal, very quick, so you can digest your food for a few minutes. And the name of the presentation is Bellyache, not from a political standpoint now. We'll have enough of that for a while. Abdominal pain is sort of nebulous. Everybody has it. Shoot, nobody really knows what to do with it. But the causes of abdominal pain are usually in 4 areas: infection, neoplastic, which is like a cancer cause. There's blockage, bowel, artery, veins, and intestinal syndromes, which now are thousands. I mean, you have every possible genetic abnormality known to man. I mean, almost. Pain can sometimes be serious, and people usually need to recognize the causes. The most common examples of abdominal pain are, gastritis, alcohol-induced, indigestion, constipation or obstipation, viral causes like gastroenteritis, menses with ovarian cysts, etc., irritable bowel syndrome, food poisoning, gas bloat syndrome, lactose intolerance, ulcer disease in the stomach, duodenum, colon, PID, which we don't see much in my area, but I'm sure the gynecologists do. Hernial problems can affect anything from the esophagus down to the rectum. Biliopancreatic problems such as hepatitis, acute hepatitis, viral usually, gallstone problems, and alcohol-induced pancreatitis. Kidney stones, endometriosis, Crohn's disease or ulcerative colitis, urinary tract infections with pyelonephritis, gastroesophageal reflux disease, appendicitis, and diverticulitis. Those are the 2 that are probably the most common. There's a doctor in England named Zachary Cope who wrote a very small little book in about, I want to say 1890, called The Early Diagnosis of the Acute Abdomen. It's still used in all medical schools today. It's on its 22nd edition. And if anybody's interested who's a healthcare professional, get Dr. Cope's book. Zachary Cope's his name. And he died in 1940 or something like that. But it's still required information in medical school. When to seek help? Usually when the pain is severe or recurrent, or if there's fever over 102 and it's persistent, nausea and vomiting for 2 days or greater, signs of dehydration, usually based on urinary output, inability to pass stool, especially with vomiting, painful, frequent urination, especially if blood's in it. Let's see, if the abdomen, anywhere in the abdomen or back is extremely tender to touch. If there's any kind of pulsatile abnormality, especially under the belly button. Pain lasting more than 3 to 4 hours, that's a crescendo. Immediate attention needs to be directed to people who vomit blood, who have bloody or tarry stools, again, if they have a hematuria. Difficulty breathing associated with abdominal pain. Sometimes people have COPD and they have abdominal distension, severe pain affects their diaphragmatic excursion, and pain to breathe is more than they can tolerate. So they become hypoxic very easily. Pain during pregnancy is always something that people need to seek help for. If you have associated pain in the chest, neck, or shoulder, it's also recommended to check it out. There are thousands of causes of pain. Types of pain are usually characterized by intense, sharp, dull, gnawing. All of these adjectives are real important to describe pain. There's probably 30 or 40 different adjectives to describe it. When somebody takes your history, the history should account for about 80% of the diagnosis. Nowadays, we have MRI, CT, MRA, ultrasound, PET scans. We have everything known to man. Usually the diagnosis is made before all that. Those are just used for reinforcement. Whether the pain occurs, if it's intermittent, if it occurs day or night, before or after different meals, what helps it, what hinders it, what alleviates the pain, what makes it worse, duration, when did it start. Chronic pain usually is greater than 3 months. Subacute pain is less than that, between 3 and about a day or 2. Acute pain is a day or 1 or 2 days. If the pain radiates, that's important. And let's see, medications causing pain. As you well know, people who take Nexium or Prevacid or any of the PPIs can cause gastric pain. And that's what we're giving people that medicine for. So it's very difficult sometimes to make the connection exactly what the cause is. Let's see. Pain management is also a big problem when somebody has pain, because oftentimes people are on a pain management program and then they have pain. And then we worry about whether or not it's real or imagined. And that becomes a real difficult situation, because we don't want to be inhumane, but we don't want to hurt the patient. So it's hard to make that call. Differential diagnosis can be quite involved. It takes a while to make the specific diagnosis. It's usually related to the cause. Antibiotics can also mask the source. I'm trying to talk with our ER doctors not to give antibiotics if there's a potential surgical problem, because sometimes that can affect the way the patient responds after the antibiotics are given. Especially if you have appendicitis, you don't want to give any medicines that can mask that. Appendicitis is one of the most difficult diagnoses to make. It's probably one of the most common. Gallbladder disease occurs in 1 out of 4 people in the United States throughout their life. So most people, 1 out of 8 women have hysterectomies in the country. So yeah, it's interesting that abdominal pain usually presents in 2 ways. There's either somatic or visceral pain. You hear that people who have appendicitis sometimes present originally with pain right around the umbilicus. That is called visceral pain. Any pain that is due to distension of the bowel or the gallbladder or to the common bile duct or the pancreatic capsule or anything initially causes pain in those fibers in the wall of that organ. That is called visceral pain. That goes straight back into the spinal cord and is interpreted as pain right here. Now when it progresses and people have inflammation that actually extends to the somatic peritoneum, where it touches the outside layer of the abdomen, then it becomes more localized and we can be a little more accurate in our diagnosis. But that's called somatic pain. Sometimes it's hard to differentiate those two. We have quadrants, usually there's 6 to 8 quadrants depending on how you look at it. But about right upper quadrant pain, left upper quadrant pain, and whether it's crescendo or intensity. Let's see. Things that can make it very difficult diagnosing the pain is compression fractures of the back can cause abdominal pain with radicular radiation around the abdomen, and usually missed. Nerve problems, whether it be neoplastic or compression at a joint, can cause similar problems as well. Neoplasms are our biggest problem and the biggest potential litigation area for abdominal pain. Sometimes people have to be watched. They're admitted to the hospital. We watch them for 2 or 3 days and decide whether or not the pain is improving or worsening. If it's worsening, then it'll become more intense on examining the serial examination and lab determination. And usually they are explored if they have persistent acute abdominal pain. Sometimes people can have clots that go to the arteries in the abdomen and are clots in the veins in the abdomen. I recently had a patient in Amarillo who, in fact, it's a patient of mine who I've been talking about on the phone, recently developed a portal vein thrombosis, which is a very, very bad problem. And that's where people have a blood clot in the vein that comes from all the intestine that basically plugs the liver. And in that situation, you are facing a couple of different things. Either they have to take the clot out of the portal stent it now. They also use heavy anticoagulation, and but you know, possibly liver failure and liver transplantation is the possible option for this patient. So it's a bad problem. Any questions, anybody? That's it, really. But abdominal pain is very complex and can change rapidly over just a few hours.
So Dr. Randall was talking about some of the things you do in the hospital and the OR. What do you see, like short-term, long-term here?
Here, you know, I'm surprised how many people have MRSA injections in their skin. I'm sure that a lot of it's induced by, you know, the bay.
Yeah.
Mosquitoes. I mean, everybody gets mosquito bit and potentially has inoculation of bacteria every time that happens. But I've been impressed with that. Also, sometimes people wait too long to have their problem evaluated. Usually we see them a little late down the path, but hopefully that's going to change. We do want to open the scope of the hospital up. The hospital's been sort of a sleepy little institution that just does colonoscopy from time to time. And we really do want to improve the capability of the hospital.
So the colonoscopies, you're going to start doing those on a regular basis too?
No, I don't do any endoscopy. I think we need to try to attract a gastroenterologist.
Well, a lot of businesses go to the corpus constantly, so
We need a gastroenterologist here.
good resource.
So once we do that, that will be very helpful.
A question for you. I have a son that has been diagnosed with Gilbert syndrome, where he has elevated bilirubin levels from time to time.
Right.
And but there isn't. You can read some things online, but there isn't a lot of information about how you should be caring for yourself to decrease the possibility of those outbreaks.
Usually with Gilbert, that's Gilbert's syndrome in English. It's usually secondary to a enzyme deficiency that converts bilirubin in the liver. So people have a elevated direct bilirubin fraction. So anytime they have their liver function studies done, their bilirubin is 3 or 4, and the direct fraction is high. I mean, the indirect fraction is high, I'm sorry. And it always makes us think that somebody has either hepatitis or biliary stone problems.
Not all those have been tested for.
But,
and ruled out.
and usually it's something that just needs to be watched. I don't think there's any real treatment for Gilbert syndrome.
Hydrate and rest if you.
Right. You know, we see that with people with any kind of blood discouragement like hemophilia, sickle cell. They break their blood cells down, their red blood cells down, and that heme is metabolized in the liver, and it causes an elevated bilirubin as well. So it's hard to figure out what's going on there sometimes. But that's about it, guys. Thank y'all for being here.
Thank you.
Well, thank you for putting this on.